Obviously, I think most of us, are influenced in the second-line setting by what we do in the first-line setting. We have a very good second-line drug, pemetrexed, but many of us are using it up front. Our standard now has really been principally docetaxel from a cytotoxic view. Erlotinib has a very controversial role in the wild-type population. But recently, we had some data with the new anti-angiogenic agent. Roy, can you kind of walk us through the Ramucirumab data? First of all, what is it, and what did it show?
Right. So, targeting angiogenesis, to the last conversation, I think makes a lot of sense. There are many ways that can actually help. It can help with drug delivery, and that's been shown from some studies, for example, out of Harvard. And then it can also, of course, help, with tumor dormancy. Any micrometastatic disease, you block angiogenesis and you prohibit that from growing. The question is, how active are these agents in targeting angiogenesis, and is VEGF the whole story? Well, of course, bevacizumab is more of a trap. It's an antibody against vascular endothelial growth factor, so it's not working directly on any of the cells. It's working on the ligand that binds to the cells, whether it be the endothelial cells or the tumor cells. It works on both. Ramucirumab, which just recently approved and has been in development for almost a decade, is actually an antibody directly against the VEGFR2 receptor. So it's working on the receptor on the endothelial cells, as well as, by the way, on the tumor cells. It's been shown that some lung cells, tumor cells, have this. So it's a more direct approach, potentially more potent at blocking angiogenesis. And the trial was presented at ASCO, had a positive result. Things that impressed me about this trial was a combination of docetaxel plus ramucirumab versus docetaxel in refractory patients, both squamous and adenocarcinoma both. And the thing that was, of course, interesting was the toxicity profile looked quite good. Everyone was concerned, squamous patients, the experience with bevacizumab, would there be hemoptysis, bleeding, and that was not the case. So it could be given safely to both groups of patients. And actually, the survival benefit was seen. The issue is, was it robust enough? I believe the hazard ratio was somewhere in the 0.85 range, this being in refractory patients, but it was a survival benefit. Those data were presented at ASCO, and the drug did get approved, so it is available. I think it definitely has a place in lung cancer. The median with a hazard of 0.85, the median difference would be a month and a half. Again, median only matters to one patient. Some have more, some have less. My feeling is that we have activity here. We need to figure out, are there biomarkers? Are there other combinations where this could be used? Perhaps it could be used with other chemotherapies, with immunotherapies, with other targeted agents. But I think there's definitely a future for this drug, and we're all just beginning to get some experience using it because the trial was done in a very limited number of sites.
The other thing that impressed me about the trial, and this comment is taken in the context of an incurable palliative setting. Our patients are often symptomatic in this setting, and one thing that you can do to make a patient feel better and relieve their symptoms is to shrink their cancer.
Right.
And there was a significant, I thought, clinically relevant increase in response rate from about 13–14% or so up to about 22–23%. So, I think, and there's probably more minor responses that wouldn't get coded as a response. So, I think, thinking about it as a truly palliative sort of advantage in that patient population also.
Yeah, and I absolutely agree. And just to highlight what Dr. Herbst brought up, this works in squamous. We can now give an anti-angiogenic in the squamous population.
So, Roy, you did a very famous or infamous, I don't know which one, beta trial in which you combined an anti-angiogenic agent with erlotinib. Erlotinib is a drug we use second, third line. What are your thoughts about, if you were to choose erlotinib in the second or third line setting, would Ramucirumab be a potential partner?
Oh, absolutely. So I trained with the late Judah Folkman, and then when I moved to MD Anderson, I worked with Josh Fidler, and the whole idea was to target both the tumor and the microenvironment. And actually, EGFR, when you upregulate EGFR in a tumor cell, that stimulates VEGF, vascular endothelial growth factor, that the tumor cell makes, that then stimulates the microenvironment. So the idea of using an anti-angiogenic and anti-EGFR together makes a whole lot of sense. It's sort of a two-pronged approach. And the work that we did, actually the first phase ones that Alan Sandler and I did many years ago of bevacizumab or erlotinib, before either drug was approved, showed amazing results. Now, in retrospect, some of those amazing results were probably EGFR mutant patients, and we didn't know about it. Right. But I believe that there was more than that. And actually in the phase 2s versus chemotherapy, again, in unselected populations, we saw a benefit. And then the beta trial, 600 plus patients, worldwide trial did show a great improvement in progression-free survival. I think the number was about 0.6.
And response.
And response was double or more. The problem was the overall survival was the same, and never fully explained that. One thought was that could be crossover, not on trial, but because there were many other active agents available. But clearly, the one group that we, in retrospect, when we went back, and that was an area where we didn't have tissue in all patients. Now that wouldn't be the case. We did see the EGFR mutant group did better, which explains some of the data we heard from Tom earlier.
I think what might be even more exciting would be the combination of immunotherapies plus the Ramucirumab. So I think that would be perhaps, although the erlotinib and an anti-angiogenic inhibitor still has some compelling data, I think that we need to move forward in the field.
Okay. Before we